Welcome to ATCM, the Emergency Medicine channel, shall I? Today I'll be presenting a case of 25-year-old male who presented to ER with alleged history of drug overdose. According to his parents, he had taken 3 strips containing 20 tablets each of tab paracetamol 650 mg, that is equivalent to 39 grams, and 3 strips containing 10 tablets each of tab cetirizine 10 mg, that is corresponding to 300 mg in his pocket. So on arrival to our ER, on 10-second assessment, patient was conscious, he was drowsy but erosible, airway was patent, there was no secretions, gurgling or pulling of saliva. On breathing, air entry was bilaterally equal. Patient had a respiratory rate of 20 breaths per minute with a saturation of 98% at room air. On circulation, patient had a BP of 100/70 mmHg with a pulse rate of 62 per minute. On disability, patient had a GCS of E2V4M6. And on exposure, patient was febrile with a GRBS of 101 mg per deciliter. So as adjuvants to the primary survey, initially we had done a blood gas analysis which gave a pH of 7.3 with a PCO2 of 42 and bicarbonate of 24. There was no any
poisoning blood gas will be useful.
If there is any salicylate poisoning, we can do.
What are the acid-base disorders you get in salicylates?
We can get metabolic acidosis can be there. In paracetamol poisoning, if the patient is having
metabolic acidosis, then salicylates. It's a special topic. Salicylate, what are the metabolic abnormalities you are going to get? Acid-base disorders.
Metabolic acidosis.
Should read properly. There are 3 metabolic abnormalities you are going to get in salicylate poisoning. You have to read it. Okay. So it is not a very straightforward problem in salicylate poisoning. You get different types. With different time period, you get different type of acid-base disorder. Okay.
Then in case of paracetamol poisoning, initially if the patient is having multiple episodes of vomiting, patient can develop metabolic alkalosis, patient can go into. In the later stages, if there is lactic acid production, then the patient can go into the metabolic acidosis.
Okay.
Those are the usual in paracetamol poisoning.
Okay.
So here the patient had
There are so many poisons can produce metabolic acid-based disorders. Cyanide. So many things are there. You have to read. Okay.
So here the patient had a pH of 7.3 with a bicarb of 24, PCO2 of 48. Lactate was 1.9. So patient didn't have any acid-base abnormality.
Okay.
So along with the...
But he was unconscious, no?
He was drowsy but erosible.
Okay.
Along with the blood gas analysis, we had also taken an ECG to know whether there was any other co-ingestion which may alter the QTC. So in the ECG, there was no QTC.
What drugs in this group can produce alteration in QTC?
If tricyclic antidepressants patient is taking.
Cetirizine, levocetirizine is taken, no?
Yeah. It can also cause QTC prolongation. Okay. But in his ECG, it was normal. There was no QTC prolongation. Coming to the sample history, the 25-year-old male was brought to the ER with alleged history of drug overdose. Bystanders mentioned that patient was extremely drowsy at home. He was last seen normal at 10 a.m. the previous day, and following which he did not wake up till 4 p.m. that day. As a result, the bystanders took the patient to an outside hospital. From there, IV fluids was given, and following that, he was brought back home. Even reaching the home, patient's sensorium was low and he was found to be drowsy. Hence, the bystanders took him again to the hospital at 8 p.m. And following that, the bystanders found that there were empty strips of 3 strips containing 20 tablets each of tab paracetamol 650 mg, which would amount to 39 grams, and 3 strips containing 10 tablets each of tab cetirizine 10 mg, which would amount to 300 mg in his pocket. So this gave a suspicion of drug overdose. And then following, patient had 1 episode of vomiting in the hospital. So in hospital, gastric lavage was given for the patient, and patient was started on N-acetylcysteine injection 150 mg per kg and then referred N-acetylcysteine. Injection was
Injection.
IV was started. Infusion was started. It was started over 1 hour and then referred to our hospital. So on arrival to our hospital, already 15 hours post ingestion was this, and then the patient came to our hospital. On arrival, he was drowsy, but he was arousable. So we had then taken serum levels of the paracetamol. We have sent a serum level of paracetamol. Also toxicology screening for other drugs to know whether any co-ingestion also was sent. And then we couldn't
Toxic screening of blood.
Blood was sent.
What are the blood screening you can do here?
Here we can do for the drugs like benzodiazepines can be tested. We can test for the alcohols. We can test for any opioids, TCAs. We can look for any tetrahydrocannabinoids.
Blood or urine?
Blood. Given urine sample also we can test these things.
We do in our lab, we do urine sample. Most of the labs do urine for detection of all these things, not blood.
Yeah. Urine sample here we can do for benzodiazepines, barbiturates, tricyclic antidepressants, opioids, tetrahydrocannabinoids, cocaine, ketamine, etc. can be tested. So we had also sent the analysis for all these to know whether any co-ingestion was there. And since we couldn't get a report within 8 hours, since it was a Sunday, so we had already started the patient on the NAC infusion protocol.
Okay.
So we had
what is infusion protocol?
We have to give for 21 hours of period. So initially in the first hour we will be giving 150 mg per kg in 200 ml of D5 over a period of 1 hour. Following that, we will be giving 50 mg per kg in 500 ml DA5 over a period of 4 hours, and then 100 mg per kg in 1000 ml for period of 16 hours. So we had initiated the patient on this NAC infusion, and then we had monitored, we had sent the routine lab investigations, which included the PT-INR, the liver enzyme test, RFT, creatinine, etc. were monitored. So the initial LFT in INR, LFT, OTPT came to be as normal, and INR was 1.2. So then we planned for a serial monitoring
what
of
is
INR.
Albumin level?
Albumin here was initially normal. So then since the INR was 1.2, we had planned for a serial monitoring.
Interpret LFT. Tell me how to interpret LFT. Bilirubin.
Total bilirubin
Bilirubin can be elevated in which all conditions? Pre-hepatic, hepatic, post-hepatic jaundice, it will be elevated. Indirect and direct. Okay. Then SGOT, SGPT? Liver injury, liver structural damage. SGOT and SGPT, is there any difference? Which condition SGOT will be elevated more than SGPT? Alcoholic hepatitis. Okay, then AG ratio and albumin globulin. So what happens to albumin globulin in liver disease?
Reversal of albumin.
Reversal occurs in chronic liver disease. Acute?
Decrease. Albumin.
Normally nothing will happen. Albumin, what is half-life? Half-life of albumin in your blood. How many days? It takes nearly 3 weeks, 21 days. Okay. But if you have a vascular leak due to something like dengue or sepsis, then albumin reduction can be faster. Otherwise, it takes longer time. That's why albumin is a marker of chronic liver disease. It is not a marker of acute liver disease. Then what is the next investigation? She has already told. GGT is a marker of alcohol. Okay, then INR is the most important marker of a function of the liver, acute function of liver. So whenever it elevates, you should suspect a liver injury that is damaging the liver function. What is a panic level? Means
1.5, above 1.5.
So above 1.5, you have to be very careful. Below 1.5, it's okay, acceptable.
So in this patient, we planned to serially monitor the INR values, and then we continued the NAC infusion. So this INR value slightly was raising up from 1.2.
So if you continue the NAC infusion, any problem can happen?
No.
nothing. It is a safe drug.
Hepatoprotective drug. So in the INR values from 1.2 mildly elevated to 1.3, 1.4 in the next days, and by the time we got our toxicology values also, in the toxicology serum paracetamol level was found to be 157.
Okay.
So we had plotted the Rumack-Matthew diagram, and then in that it came to be as above the treatment line.
Okay.
So we plan to continue our infusion, and we planned for sending a next repeat serum paracetamol levels as INR also was getting elevated. Meanwhile, the toxicology reports also came positive for MDMA and methamphetamines.
Okay.
So, and then the repeat paracetamol levels came to be below the 10, and then we had also given a gastromedicine consultation. In view of their opinion also, then we had stopped the NAC infusion and made into oral drugs.
Okay.
We had started NAC as oral drugs. So so in this mainly we had focus on the paracetamol poisoning. Patient basically had paracetamol poisoning. So and also we found that there was presence of MDMA.
Okay.
So today we'll be discussing about the MDMA features.
So is this patient is having any features of MDMA toxicity?
No, patient was not having any features.
Amphetamine is a stimulant. Here everything is opposite. That may be co-ingestion of cetirizine, paracetamol and all. We don't know.
So now MDMA is basically 3,4-methylene dioxymethamphetamine, and commonly it is known as ecstasy or molly.
Okay.
So basically the pharmacokinetics is that it will increase the release of the endogenous catecholamines, mainly norepinephrine and dopamine, and thereby it will block the reuptake of these into the presynaptic vesicles. So the main clinical feature, mainly this MDMA is available in tablet form, 50 to 200 mg tablet forms, and the peak effect will be within 2 hours, and the effect will start coming down by 4 to 6 hours. And the clinical features is that if you look into the vitals of the patient can come with hypertension, tachycardia and hyperthermia. These are the
everything increases.
Everything
BP increases, heart rate increases, temperature increases.
So these are in the vitals, and then coming to the CNS effects of the MDMA, it can cause agitation in the patient, it can have hyperactivity, anxiety and even delirium. In very toxic levels, it can cause seizures, and patient can go into status epilepticus. And then about the liver damage in MDMA, it can initially cause hepatitis in the patient, then it can progress into centrilobular necrosis and hepatic fibrosis. So in these cases, we will get the LFT as elevated, and we can see patient presenting with abdominal pain and vomiting. Patient can also develop jaundice in the later stages with the elevation of bilirubin, AST and ALT. Then coming to the features of hyponatremia, the people who take MDMA will be having increased fluid intake. So thereby patient will develop dilutional hyponatremia, and the hyponatremia may be very severe that some patients may develop seizures, confusion, cerebral edema or even cerebral herniation.
Okay.
Then patient also might develop serotonergic syndrome findings, that is patient can develop autonomic dysfunction, abnormal neuromuscular activity and altered mental status. So these are the main symptoms of MDMA toxicity as such. Then coming to the differential diagnosis,
coronary artery disease, stroke, they all can happen. Young patients die due to MDMA because of acute myocardial infarction and arrhythmias.
then patient, in these patients, the differential diagnosis to be kept is usually we always look for the other sympathomimetic drugs which were very common in the previous days. We usually look for cocaine, amphetamine and methamphetamine. Okay. The major difference between these drugs and MDMA is that here the patient will present with sweating. In the other amphetamine groups of drugs, sweating will be not there. It will be, and since it is anticholinergic action, they will be fully dry. So in these patients, they will present with diaphoretic action. So this is how we make difference between the both groups. Then coming to the laboratory evaluation, as we have already said, we can look for point of care glucose, because since it is affecting the hepatic, patient can go into hypoglycemia. Then we can send the toxicology serum levels for amphetamine, salicylate and the MDMA levels. ECG should be ruled out for any co-ingestion. And then basic electrolytes, mainly sodium should be looked into these patients. Then the RFT, LFT coagulation profile should be sent in these patients. So these are the lab investigations. And coming to the management in MDMA toxicity, initially we have to secure the airway, because since there can be severe hyponatremia and patient sensorium going bad, it can affect the airway. So airway should be secured. And breathing part, usually MDMA does not have any major side effects on the breathing part. Coming to the circulation, as said, patient can have hypertension. So the initial drug of choice for hypertension is benzodiazepines. If it is not getting controlled with the benzodiazepines, then we can go ahead with the sodium nitroprusside. Then if the patient is
Beta blockers, any problem?
Beta blockers are not usually recommended for MDMA hypertension. Then if the patient is presenting within 1 hour of ingestion, here also gastric lavage is useful in case of MDMA. Then coming to the cardiac effects, as we have discussed, it can cause cardiac ischemia. And if the patient is presenting with severe chest pain, then aspirin or nitroglycerin can be given for the angina. Then coming to the psychomotor agitation, again we are preferring benzodiazepines, and sedatives also can be given for controlling the agitation part. Then patient can present with hyperthermia, that is mostly it will be above 107 degrees Celsius. So here paracetamol is not the preferred drug of choice. Here we have to go ahead with the cooling techniques. So if it is severe hypothermia, then we can go for a ice bath, and if it is mild to moderate, then we can use cooling blankets, and combination of cool water IV fluids can be given for the patient. Then coming to the hyponatremia part, it is
serotonin syndrome also can be there.
Yes. Then coming to the hyponatremic part, patient here it is because of volume, because of more intake of fluid, it is dilutional hyponatremia. So we have to restrict the fluid intake of the patient. And if the patient's sensorium is going bad, then we can correct it with 3% saline. That is with the hyponatremia. And if patient is going into seizures, preferred drug of choice is benzodiazepines. Then if patient is having serotonin syndromes, for that also we prefer benzodiazepines with or without cyproheptadine. Cyproheptadine.
Where it is useful other than this? Inducer, and other one is migraine.
Migraine.
Okay. So is it available?
Yes.
It is available.
So these are the main symptoms and the treatments. So whenever a patient comes with toxicity, we have to make sure that we send the toxicology levels for all these recreational drugs, because it is very common in use these days.
Okay.
This is with them.
Only thing is, this patient is not having acute symptoms of toxicity. Patient is having symptoms only because of paracetamol. Other things are not there, but on examination, lab examination, it was found that MDMA is positive. It's a medical legal case.
Yes, we have to intimate to the police.
That is a must.